Dr. Ganuka is the president of Association of Physicians of Sri Lanka to give us 1 minute address to our students, and then we start. So first, Madam Alka Deshpande, Madam, first you address, and then Dr. Ganuka will address.
Dr. Jyotirmay Paul, Dr. Nandini, our guest from the neighboring country, Sri Lanka, and all the delegates. It gives me a great pleasure to attend this master class because it's a wonderful, interesting case which will be presented and will be discussed. It will benefit not only PGs but even young consultants because it is not only information but it is the experience and expertise which is going to teach us so many things. We have Dr. Nandini has invited neurophysician, a gastroenterologist, a chest specialist, and I am an internist like you all. So I think without wasting the time, we should go ahead. I welcome our people from neighboring countries, and we will be very happy to collaborate with them. Thank you.
Thank you. Now I request Dr. Ganuka from Sri Lanka, is the president. So say a few words.
Thank you, Jyoti. Thank you, Jyoti. Dean, Indian College of Physicians, Dr. Aloka Deshpande, and all the other distinguished participants, Jyoti, Nandini, and all the others. So it gives us as well a lot of pleasure in joining with this very important academic activity. I think this is the third one we are joining with. Our PG trainees have also been benefited a lot, as well as consultant colleagues who become panelists. And I believe this activity should go on every 2 monthly or so. We'll be giving our fullest support to this. I would like to thank Jyoti and Nandini and other people who are taking the leadership, leading this very passionately to improve the knowledge among postgraduates. So thank you so much and wish you all the very best for this program. Thank you, Jyoti.
Thank you, sir. So now I request Professor Nandini Chatterjee, please start the proceeding and invite our student to present.
Thank you, sir. So today we will be discussing a case of a drowsy patient who also had a history of chronic diarrhea and rapid weight loss. I would like to invite Dr. Shakshi Puri to start her presentation without delay. First, Shakshi, you introduce yourself and then go on to the presentation.
Thank you, ma'am, for introducing me. Very good evening to all my respected teachers and respected panelists. Good evening to all my dear colleagues and friends. I'm Dr. Shakshi Puri, DNB trainee, general medicine, and I'll be discussing a case of a drowsy patient with chronic diarrhea. So we got a 45 years old male patient residing in Noapaड़ा, South 24 Parganas, West Bengal, who presented with complaints of drowsiness from the last 2 days. And on the day of admission, he had one episode of generalized convulsions. Prior to this, patient had already had complaints of headache, inattention, and increasing forgetfulness from last 2 to 3 weeks associated with generalized weakness, appetite loss, and in the last 3 months, he had a weight loss of around 9 to 10 kilos. Patient had no history of travel or any head trauma. There was no complaints of cough, hemoptysis, joint pain, any rashes, increased urinary frequency or dysuria. Patient did not have any past or any recent history of COVID-19 infection. Patient is a non-diabetic and non-hypertensive, was not on any regular medications. There were no complaints of any pain, abdomen, vomiting, hematochezia, abdominal distension. Patient is a non-smoker, non-alcoholic, no history of any substance abuse or high-risk behavior. He had a history of undergoing hernioplasty for left inguinal hernia in 2017, and his entire procedure was uneventful.
Okay, thank you, Shakshi. Wait there.
Yes,
so we have this middle-aged male who had lost around 9 to 10 kgs in the last few months. So can you tell me what are the causes of rapid weight loss in any patient?
Ma'am, in this particular age group, I'll be thinking of an infective cause and a non-infective cause. Among the infective causes, since we live in an endemic country of having tuberculosis, it will be one of my differentiants. Yes, the patient can have an immunocompromised state, can have HIV. In non-infective causes, I'll be thinking about any malignancy, could be lymphoma, or any metastasized, could be local or metastatic malignancy, could be an endocrine cause like thyrotoxicosis, though unlikely in this case. And it could also be due to metabolic disturbances, since he was had an appetite loss.
I'm asking you about the weight loss, but when we combine the weight loss along with the seizures and the neurologic manifestations, then the whole list becomes a little shortened. In that case, what would you like to keep in mind? Your patient who is presenting with seizure and drowsiness and also has such a history. So now, what would you like to keep?
Ma'am, malignancy, tuberculosis, could be HIV as well.
And electrolyte disturbances, you wouldn't
Yes,
like?
ma'am. Yeah, as I said earlier, it could be metabolic disturbances, could be an electrolyte imbalance leading to such a kind of a neurological presentation.
Okay, we have lots of discussions from our respected panelists today, so I wouldn't ask you some more. I would ask you to continue with your history.
Yes, ma'am. Continuing with my history, on further inquiry from the patient, we got to know that patient also had history of passing loose stools, which were watery, small in quantity, were around 3 to 4 episodes per day, and it was going on from last 1 month. It was associated with passing mucus, tenesmus, there was no foul smell or any bloody discharge, and the patient was also having low-grade fever from the last 2 months.
Okay, thank you. Now, since Dr. Chamara is here with us, I will just ask him just 1 or 2 things. Are you there, Dr. Chamara?
Yes, I'm here, Nandini. Yeah.
Yes, this patient has many things in his history, but I would just like to tell the students, like, what do you think is his type of diarrhea, like large bowel or small bowel type of diarrhea? How could it be differentiated clinically from history?
All right. And first of all, I'm very much privileged and humbled to be a part of this collaborative workshop. And so let's go to the question. Now, she very nicely described the diarrhea the patient was having. So before coming to this differentiation of small bowel and large bowel diarrhea, let me very briefly talk about what a chronic diarrhea is, right? So basically, the diarrhea itself can be defined in the terms of increased stool frequency, or in terms of consistency or stool volume or weight. And usually when it comes to patients, the concept of diarrhea often focuses around the stool consistency. Right, so to make some uniformity, because the patients might describe it in different ways. So we have the Bristol stool chart, which gives an objective assessment about the diarrhea. So it goes from type 1 to type 7. And type 1 is basically...
Sorry for interrupting. I was asking about whether you think what kind of diarrhea this patient is suffering from, or how to, I would like you to be specific.
All right, okay. So then it is the clinical differentiation of small bowel from the large bowel diarrhea. So I must tell you that the great old golden methods, the history is the most important thing. So in this particular patient, the patient was having watery stools and he was passing small amounts, and then he was having some rectal symptoms. So all these things would suggest towards a large bowel type of a diarrhea. Physiologically, the small bowel is involved in mainly digestion and absorption. So if we have a problem in the small bowel, usually what we would see is there's a lot of malabsorption. So there might be undigested food particles in the diarrhea, as well as there will be steatorrhea, there will be malodorous, bulky, pale stools. But in contrast, in the large bowel, most of the time the digestion and absorption have already occurred. So stools tend to be small in quantity, and there will be a lot of watery type of stools because water absorption mainly happens in the colon. And also people tend to have a lot of mucus and blood in the stools. And also they can have tenesmus and other rectal symptoms. So in this particular patient, the history suggests more towards a large bowel type of a diarrhea.
Okay, thank you. Thank you very much. Shakshi, let's
Yes, ma'am.
now delve into what you found on examining this patient.
Ma'am, we started with the general survey examination of the patient, which revealed that the patient had mild pallor. Patient was vitally stable, and his blood pressure was on the lower side of 100 by 70 mm of mercury. On coming to the lymph node examination, the patient had bilateral supraclavicular group of lymph nodes palpable, which were palpable more on the left compared to the right side. We found matted lymph nodes on the left side, which were around 2 to 3 millimeter in size. Consistency was firm, they were non-tender, and they were not attached to the underlying structures. We also found matted lymph nodes on the right side, as well as over the middle and the lower cervical group of lymph nodes on both the sides. However, no other peripheral group of lymph nodes were palpable.
Okay.
Dr. Sakshi, 1 minute. You are
Yes,
saying
ma'am.
2 to 3 millimeters in size. Are you sure? 2 to 3 millimeters. It won't be even palpable.
Mhm.
How will you
Ma'am,
say 2 or
since
3 millimeters?
Ma'am, they were in. If I show you the picture, I felt they were multiple group of lymph nodes which were stuck together.
That
like
I
in the
agree. That
matting.
I agree. I'm only talking about the size of the lymph nodes.
Um,
And on top of that, you are describing their characteristic that they are matted. So 2 or 3 millimeter. Can you imagine how much is the size? 2
ma'am,
millimeters?
sorry,
What are you doing?
sorry, ma'am,
Don't be
sorry.
nervous. Just try to answer ma'am's question.
Yes,
Remove
ma'am.
your hand from the computer. Yeah.
Yes, ma'am. I just went. Yes, ma'am. I agree with you. Yes,
Was
ma'am.
it a typo? I would ask the most obvious question. Was it a typo? Typographical error?
Yes, ma'am. I guess so. Instead of writing centimeters, it became millimeters. Sorry, ma'am.
That is a very
That
great
is,
insight on your part.
I'm
Anyway,
so sorry, ma'am.
ma'am, Dr. Deshpande, should we proceed?
Now I my another question to her. Yeah, it must be
Yes.
centimeter. Otherwise, it won't be palpable.
Yes,
And
ma'am.
you
It
can't say
became
that it is matted. Okay. Now you said supraclavicular. Is there any particular significance of a supraclavicular lymph node in
yes,
view of
ma'am.
your? Yes. What is it?
Ma'am, it might or might not be connected with my case, but the supraclavicular lymph nodes are usually palpable in a case of gastric malignancy. So if we get a supraclavicular lymph node, we should think about
Yeah,
it
but
might be involved.
in any infradiaphragmatic malignancy, do you get bilateral or you get unilateral?
Ma'am, usually as per I know, we usually get it on the left side, which is also known as the Butcher's node.
Okay, okay. So in view of the middle-aged patient, history of rapid loss of weight, history of subacute dementia, and this, you would also keep, as you had said, malignancy in mind. Okay?
Yes, ma'am.
Go ahead,
Yes,
go
ma'am.
ahead, go ahead.
Okay.
Ma'am,
Here,
I should agree.
just a few slides of how to assess and what to be seen in case of lymph nodes. I'm sure all the students they know about this, that we need to note the size, shape, consistency, mobility, tenderness, whether it's matted or discrete, and also the overlying skin condition when you palpate a particular lymph node. Now, when would you consider a lymph node clinical? The size is important, and if the size is greater than 2 to 2.25, then you may have it in your mind that this may be pathological. And as ma'am was saying, and also that you must know that some sites of lymphadenopathy are very suspicious or more important in terms of being pathological, like the supraclavicular, scalene, mediastinal, or intra-abdominal. If you find it on USG, you must beware of it. Consistency can give you some clue. If it's a hard lymph node, you may think of a metastatic malignancy. If it's rubbery, you may think of a lymphoma. If your lymph node is fixed either to the underlying structures or the overlying structures, then it means that either there is inflammation or it may be malignant. We have heard the term scrofuloderma, where we may find that a tubercular lymph nodes, the caseous materials, they find their way onto the overlying skin through a sinus. So you must look for that. Tenderness signifies inflammation. And if you do an USG, then the ratio of the long and short axis, one has to note. If it is less than 2:1, it would favor pathological enlargement. In other words, a more rounded lymph node is more suspicious than an elongated one. The next slide, please. Okay, go ahead. You skip these slides. You skip them. These are just we don't need this. We don't need this. Okay. So just a few words about what to look for or what we find significant in ultrasound, where we look for the ratio, as I mentioned, and rounded nodes are worse. Irregular margins, hypoechoic centers, they may signify tuberculosis. A peripheral halo is also significant. Next slide. Yes, the vascularity, if it is increased or chaotic, it may signify malignancy. So to stress upon the fact that a normal node is oval with a sharp margin, no matting or calcification or edema. We all know that when we do FNSC of a lymph node, when we want to diagnose TB or want to confirm a relapse, usually a biopsy is preferred. Why? Because we get inadequate tissue or we do not see the whole architecture of the gland. We may also choose an erroneous area of tissue. So next. So a biopsy is preferred when we want to diagnose a malignancy or a lymphoma, and it has a positive predictive value in a greater age if it is hard and non-tender and of a particular size. So I don't have much to say now. Now I would request Shakshi to go on with her presentation.
May I do one comment?
Yes, yes, sir.
Yes. One very common mistake done by the student when as an examiner I observe, then when, for example, is the method of supraclavicular lymph node examination. When we ask to suppose palpate showing the method of right supraclavicular lymph node, immediately they move the head to the left side. This is wrong. When I am asked right supraclavicular lymph node, you flex the neck and move the head to the right side, same side. Then put your finger between the two head of clavicle, two head of sternomastoid muscle, clavicular head and sternal head, and push your finger downward and backward. Because if you move the head downward and right side, then only two head of the sternomastoid will be relaxed, and you can palpate the lymph node properly. If you move head to the left side, it will be, you cannot palpate properly. Okay. So this what I examine, I observe, I have mentioned.
Dr.
Thank you.
Shakshi,
Proceed.
Yes, ma'am.
Proceed.
Dr. Nandini has given a very good description of pathological lymph nodes. Can you tell me what is reactive lymphadenitis?
So, ma'am, reactive lymphadenitis usually is the inflammation in the lymph nodes when there is an infection or any malignancy or any other involvement of the site which is drained by that particular lymph node.
Yeah,
So,
not
for example,
malignancy, but you have to see if there is any infective focus in the vicinity of that lymph node, the area which the lymph node drains. So you know it is a reactive lymphadenitis. While the conditions Dr. Nandini discussed are per se the diseases of the lymph nodes. Okay?
yes, ma'am.
Okay, go ahead. Go.
Yes, ma'am. Coming to the nervous system examination of the patient's Glasgow coma score was 4 out of 15. Patient was drowsy. On cranial nerve examination, we got a right-sided 6-nerve palsy with bilateral papilledema. Deep tendon reflexes were diminished and plantar was bilateral extensor. The cerebral function tests could not be tested, and the skull and the spine examination were non-contributory.
Okay, wait. We should wait here. Dr. Balamurgan, sir?
Yes, madam. Yes, madam. Yes, doctor.
Yes. Yes, actually now, since she has described the nervous system examination, we can have your
Sakshi, go back to the previous slide, neurology slide,
Yes.
with the
Yes,
pupils,
yes.
and also Dr. Balamurugan can discuss it. Yes.
Thank you, madam. Thank you very much. So,
now, what is happening? Shakshi, actually, you have to stop sharing this and you have to
Yes,
share
ma'am.
Balamurugan's slide.
Sure, ma'am. I'll do that.
before that, the history is, thank you, Dr. Shakshi, for a nice and brief presentation of the case. I understand the patient had seizure, and then the patient developed or went to drowsy state after the seizures, or even before the seizure, patient had drowsiness, because that will give the clue. Is a person, when you examine, he was having a postictal drowsiness, or even before the seizure, the person had a problem, or the person had a seizure, then recovered, and then is drowsy. That I'm not able to get that particular issue. I understand that when you examine the person, the patient was drowsy, and you couldn't examine properly because his GCS, what was the GCS you have put?
So 4. So 4 out of
4.
15.
4 is, do you think with the 4 GCS, you could say drowsy or comatose? 4 GCS means that probably
comatose.
1 something is 2. Am I right?
Yes, sir.
Which was 2? Is it
Sir, the patient was having incomprehensible sounds, so I will keep it E1, V2, and M1. Patient was not moving his limbs and there was no eye response. So probably patient had a convulsion first, and then he became drowsy, because when we saw the patient, he was not responding. But on a little stimulus, he had we got to like there were incomprehensible sounds. So that's why, sir, we put GCS as 4 out of 15. Yes, the patient had to be intubated. It will be better if we say comatose. So he will be able to tell us better.
I understand the difficulty when the person comes to the ER with seizure and drowsy. More
Yes.
examining the proper higher mental function, we are much oriented about the GCS and the pupillary size and other focal neurological deficit. I fully agree with you, Dr. Shakshi. But I understand the person was deeply drowsy or nearly comatose, and you couldn't examine. The person is inattentive, and most of the higher mental functions could not be tested in this state. And you rightly said that GCS is very poor, so we have intubated the patient. That's fine. But you could say that there was a 6-nerve palsy and bilateral papilledema. Even the comatose patient, we can do bilateral, say that. But 6-nerve palsy is, unless the person has a convergent squint, is very difficult to make a 6-nerve palsy when the person is deeply unconscious. So you can clarify that. How could you make that 6-nerve palsy when a patient who is not opening the eyes? That's the one thing.
So when we try to examine,
you not mentioned about the neck stiffness. Was that a neck stiffness or the eye?
there was no neck stiffness.
No neck stiffness. With this picture, that in the background of weight loss and middle-aged man with diarrhea, so a neuroinfection has to be considered, or a seizure, and then following the seizure, the patient is drowsy, and then we have to evaluate for the seizure and postictal drowsiness. But if it is a simple seizure and drowsiness, I can't explain the 6-nerve palsy on one side and bilateral papilledema and deeply comatose state. So with this picture, there should be a raised ICT and within a short duration as per the history. So whether the raised ICT is diffuse or from focal, one side it's going to the other side, because there is no focal neurological deficit. Whatever you say is diffuse. The one focal, you could say, is right 6-nerve palsy. Whether it's a focal or whether it's a false localizing, at this point we can't say. So I understand, again, this is a case of neuroinfection with generalized neurological dysfunction, drowsy state, and bilateral papilledema suggesting a raised ICT, a neuroinfection with the raised ICT. So there are very, very limited things that we suspect when a neuroinfection, but generally, when you say neuroinfection, meningitis, encephalitis, we don't see a papilledema, isn't it?
Yes, sir.
Yes. So with raised ICT, what are the possibilities you think with papilledema neuroinfections? So my first diagnosis would be of neuroinfection. It could be meningitis, meningoencephalitis, or encephalitis picture because the person had seizure. And there are certain meningitis can present with a seizure, and most of the time when you say encephalitis, they present with disorientation to coma with seizures. So it's a meningoencephalitis though there is no neck stiffness, it could be meningoencephalitis. One odd feature is that the person has raised ICT. So that I have to take a clue to suspect a raised ICT with meningoencephalitis. From your point, Dr. Shakshi, do you think speak for this raised ICT? Neuroinfection
Yes,
was
sir.
suspecting, but papilledema is there.
Yes, sir. The papilledema findings goes in favor of having a raised ICT. Yes, sir. There could be meningoencephalitis with a raised ICT. There could be so any space occupying lesion also there, which is leading to the raised ICT. So I was
You might have seen a lot of meningoencephalitis patients. Have you ever come across papilledema?
No, sir. No, sir. I haven't seen much of papilledema in meningoencephalitis patients.
Yeah. So when you see meningoencephalitis in a neuroinfection, one thing is that could be an abscess that has ruptured somewhere, or the infection process was going diffuse over weeks to months, and now the person presenting with raised ICT. The diffuse encephalitis process means probably a neuroinfection is going subacute to chronic, most likely in an immunocompromised person that can happen. So immunocompromised patients having a raised ICT, again, they are more prone for abscess. It could be a follicular abscess or it could be fungal. And I couldn't get much about the headache. The headache is so severe, intolerable headache that suggests more in favor of in immunocompromised patients, more in favor of cryptococcal, because it most of the time it goes in the supratentorial region. It blocks the venous drainages. So there will be severe excruciating pain compared to the all other headache of meningitis. So cryptococcal meningitis is the one thing that we can consider in this type of case. With this clinical picture, you want me to go ahead with the higher mental function examination?
Yes.
Input from Dr. Nandini?
Yes, yes. No,
Yes,
sir. I think we should directly delve into your.
Sure. So I understand this case is not actually ideal case for higher mental function examination because drowsy with the GCSs of just 4. But even then, can I put the next slide?
Yes, sir.
For examination purpose, I think that most of the time, at least MMSC you had to put in a case of memory disturbance or higher mental function is asked. So if you could examine in detail, that's fine. But the time of 30 minutes is very difficult to examine. But MMSC will give the idea about orientation and registration, attention. Here that you can divide the MMSC like this. This part is the language. And when you start with, you can focus on the attention, registration, orientation. Orientation may be to the time and space. And it tells about the next component, tells about the registration and then attention and recall. So here, what I again want to emphasize, the attention is the most important. If the person is not attentive, so then it's a very difficult because it can have an impact on all higher mental functions. So that's a problem. So first, if the person is inattentive or the person is having the mood switch or the person is having flights of ideas, very difficult to do a higher mental function examination. So in general, if the MMSC is more than 24, and then you can be pretty sure that they are doing well. But if it is less than that, we can focus. Suppose MMSC says that most of the problems in the language area, then I will be taking this person for a specific language assessment. If it's only the problem, then I will be going for the apraxia, visuospatial skills. If there is mostly in the registration and recall, I will be examining more of the memory problem. So that way the MMC gives a gross idea. So MMC, next slide please. It's a simplified standard cognitive screening test, but it's not a sensitive test of cognitive function. You check the orientation, registration, attention, they are all not real part of cognitive functions. I will come, when you say the higher mental function, we divide it into 2 parts, the state function and channel function. So these are all mostly of a state function, because the state function can be impaired in any patient with confusion, drowsiness, or delirium, as in this case. MMC relies more on verbal cognitive function, not the visual component. So it checks more of the left or dominant hemisphere. And in fact, MMC is based almost entirely on verbal assessment. And it is insensitive to formal executive functions, the frontal tests are not much tested in this MMC. And again, assessment of memory and language is very superficial, but we can get the clue. So I request in the exam, MMC is a must to come to a conclusion about whether there's a gross involvement. Then you can examine specifically. Next slide, please. So what I said about state function and channel function is that first you all should examine and be clear about the person's attention, mood, and the person is arousable. If the state function is affected, then all your channel function will be affected. So here in this case, the state function itself affected severely. So we can't go with the channel function at all. Channel functions are more specific, like memory, language, and higher sensory perception and learn motor skills. So I repeat, state function must be kept in mind when interpreting channel function. Yes, sir, there is a channel function affected, but disproportionately language is affected. Then you can say that there is a gross involvement of the all cognitive function, but language is more affected. That also localizes us. Otherwise, the state function tells the generalized problem. It will not localize anything. So the order of higher mental functions should start with attention, orientation, and concentration. Always begin with assessment of attention. If inattentive, it's very difficult. And next slide. Then go with the language. Again, when you start with the language, first start with the naming. When they have naming difficulty, when you start talking with them, they will have a lot of other comprehensions, fluency, and repetition also, when the naming itself is the problem. So start with naming and then go for comprehension, then go for fluency, then go for repetitions. Next slide. So memory is because the language is severely affected, you can't check the memory, isn't it? So then go with memory and both verbal and non-verbal. Then other cognitive functions. I'm not going in detail about the cognitive functions, and it will be a separate 30 minutes class. So I will send the slides to you. Those people interested can go through it. Next slide. Next slide. So we will focus on one is attention, another is memory today, because the job given by Dr. Jyoti said at least one function has to be clearly educated and in this session. So first start with attention. I would say that when you examine the patient, that itself you can say that the attention is good or not. When the person enters to the OPD and when you elicit the history, we can be very clear the state of the attention of the patients. If not, you can do a digit span. So normally, if you say that 9, 8, 4 to 7, they can do the digit span up to 7. Sometimes more than 5 we consider as a normal. But remember, the digit span, the reverse is not for attendance, comes more for working memory. So the digit span.
Sir,
4 to 7. Yes, sir.
Sorry for interrupting. Would you, sir, please explain to the students, like, what is the digit span? How do we?
Digit span.
Yeah.
We can. Digit span is the verbal attention. So we can ask the patient to repeat 4 or 5 numbers. They can say that, for example, you ask a patient, you can give the number, random numbers, 9, 8, 4, 2, 7. So immediately the person has to, the subject has to repeat it, 9, 8, 4, 2, 7. So that means they are attentive. Normally up to 7 digits people can repeat. So 5 or more than 5 can be considered as normal. Less than that, we can say that the attention is affected. So when you ask them to reverse in the reverse order, that's not for attention. For the reverse order, some amount of memory has to be there. So that comes as an immediate memory, not the attention. That part you have to be clear. So these are all linked. These are not clearly, we can't put a mark attention and then your immediate memory. But the attention is mainly tested as a digit span. 5 and more is okay. Next slide. So coming to the memory. So a lot of various ways of classifying the memory, and most of the neurocognitive specialists classify the memory as a working memory, declarative memory, non-declarative memory. So working memory is what you call as an immediate memory. And declarative memory could be episodic memory, or semantic memory is what you call as a long-term or a recent memory. And we'll go one by one. So as I said that you remember a phone number and then you register and then you dial that. That is more than the attention. So repeating the number is attention. Registering the number and you're dialing that number, it comes as a working memory. Hope you understand. So then declarative memory goes for a long term. So it may be an episode. When you call an episodic memory, it has 3 characters. One, there should be an episode, autobiographical. There is an autobiographical memory. There is a time tag. That memory is time tagged, and it has some context. For example, you had a batch meet last week, and you met 4 or 5 friends who were college mates, and then you had discussed about your project for your alma mater. So now you recollect that. That is an episode. You are involved in it, autobiographical, and there is a time tagged. So the last batch meet you met, that is probably on August 15, that you can say that time, and there is a content in it. So 3 features should be there to say an episodic memory. And semantic memory is what you learn as the names of the cities or the countries, and then their flag colors and everything. What we remember over years is a semantic memory. And non-declarative memory is a procedural memory, how to put the rail tube, Venice sections, and central line. These are all the procedural memories. Non-declarative memory is very difficult to test at the bedside. So we go with working and declarative memory. Next slide, please. For that, the traditional term used for the teaching purpose, immediate memory, short-term memory, long-term memory, and sometimes motor memory. The cognitive neuroscience term is immediate memory is better called as a working memory. Short-term memory is episodic memory. Long-term memory is semantic memory. And motor memory is procedural memory. So I have put that short-term memory as a working memory or episodic memory. Please. Can you put the, so
Come to the next slide.
just the previous one, previous one. Sorry. So here the short-term memory is episodic memory. I said that the last week we met, you all met as your batch mate. So that comes in episodic. So suppose you recollect an episode on the first day of our college. That is also episode. That is also an episodic memory, but that's not short-term. So episodic memory may be a short-term or long-term. Semantic memory also, yesterday you read about how all the higher mental function. So that comes as a relatively short-term semantic memory. But you could recollect the neuroanatomy that you have read during your anatomy sessions. That comes under semantic memory, which is a long-term memory. Hope you understand. So though they classified in a 2 different ways, we can equate more or less, but the equation is not all or none phenomena. But immediate memory is working memory. That's we are very clear. So episodic memory is usually short-term. It can be long-term also. Semantic memory is usually long-term. It can be short-term also. Next slide, please. So working memory is called explicit memory. All memories other than the procedural memories are explicit, and the procedural memories are implicit memories. So remembering the telephone number to dial up after looking it up is the working or immediate memory, what you call that. So the area is most of the prefrontal area, and parietal and frontal cortex for verbal, and parietal and occipital for visual. Because the working memory may be verbal or visual. What I said, the phone number and then or a random number, they memorize and then tell you after some time comes under the verbal. Suppose you ask the person, you show 3 or 4 objects in the room in a serial manner, and you ask the person to identify that again. So in the same serial manner. So that comes in the visual memory. That's also visual working memory. So this is mostly reverberating circuits in the frontal area. So next slide, please. Next slide. Next slide. Next slide. Next slide. So I'll explain in the flow chart. So whenever the previous one, yeah, whenever you get an information, let it be verbal or non-verbal. So the working memory in seconds to minutes, it directs the proper encoding location from the frontal area. This happens in the frontal area. From there, it goes to the medial temporal region for encoding, consolidation, and allows retrieval of memory trace. So I may be taking 3 minutes extra, but this is the most important part of the memory examination. If you understand that, you can very categorically, you can say that where is the problem? Is it the frontal, or is it medial temporal, or is the other cortical area? That means the lateral temporal or other cortical area. And this will help you to improve your memory power also. So that's the reason students just understand this. A working memory starts with the frontal, and encoding starts in the temporal region, and it gets consolidated. If you want to retrieve from this area, again, it has to be done by the frontal circuits. Then it goes over years as stored in the other cortical area. It gets stored as a long-term memory for many years. Again, if you want to retrieve it, next slide. The frontal lobe has to come, and then it has to pick up. So here the consolidation happens, and it starts from here. Anytime if you have to retrieve, the frontal circuit has to come. So to retrieve the stored memory, you need always the frontal. Next slide. So when the frontal lobe is affected, it causes impaired working memory. It causes impaired recall of old memories. However, memory itself relatively intact. It's the only process of locating it that is impaired due to frontal lobe function. So familiarity is often preserved, but the patient has difficulty recalling specific details and may resort to confabulation. So cues are helpful in recalling memories. These type of patients can recognize the person and then say that I have met you somewhere. I'm not able to recollect where I met. So because the problem is in the retrieval, but the storage, when you give the clue, immediately they could do that. If you're not giving clue, they will start confabulating. So whereas working memory is fine in medial temporal lobe because the working memory is predominantly frontal. And the problem is that impaired storage of new memories, new learning is very difficult for them. And very old memories may be preserved because it goes to the other cortical area. So the new learning is mostly affected, but the working memory, which is ultra short memory, is normal in temporal or medial temporal lobe lesions. There is no sense of familiarity and cues don't help. There is no confabulation. So this is the difference between the frontal lobe memory disturbance versus medial temporal lobe. Why am I again insisting that is that the medial temporal lobe is most of the time you may be seeing in Alzheimer's. Here in other lesions, especially frontotemporal dementia or frontal predominant dementias. So when there is a more confabulation or with the cue they could understand, they could recollect, it's frontal. No confabulation or less confabulation, even with cues they couldn't have a proper memory and new learning is difficult, then it's more likely medial temporal. Whereas in other cortical areas, what I say, the lateral temporal and for the visual occipital, only some remote memories are affected, usually memories that are related to particular cortical areas. With this picture, and now if the patient comes to you, you assess the working memory, you assess the new learning, then you assess the retrieval, and you go for a long-term memory, and you give the clue whether the person is able to take it up or not. This is the essence of memory testing. Next slide, please. Next slide. Yeah. So when you check with the medial temporal lobe dysfunction versus the frontal lobe dysfunction, here the working memory is severely affected in the frontal, whereas a recall is impaired, associated memory is impaired, but sense of familiarity is normal here, and cued recall is present, and confabulation is very high here. The same thing I have repeated in the slide. Next slide. So I will send all the slides as a PPT to Dr. Jyotir. You can use it. And testing for working memory, as I said, the digit span, it tests the attention. So when you ask them to come to tell backward, that's really a working memory. So subtraction of serial 7, it has both calculation and also your working memory. So that what we do in MMSC. We can ask them to repeat a word backwards. This is digit span is auditory. If you want to go for a visuospatial, pointing series of objects in your room and asking them to point the items in the same order and in the reverse series. This is visuospatial working memory. Next slide, please. So testing recent memory, what we do in MMC is very superficial. We give 3 words and ask them to repeat after 5 minutes. Of course, that's fine for a gross examination. If they could do it, we can be sure that they are not having a gross involvement in the memory disturbance. But the best way of checking this recent memory, because I again insisting the recent memory, is that we are going for an episodic memory that is most often affected in the early part of the Alzheimer's dementia. Next slide. So 3 words and 3 shapes is the best way recommended most of the time for the neuro psychiatrist, psychologist. So we give 3 shapes and we don't write this pride, hunger and cycle. We give 3 shapes. So we say that they have to recognize, and then we tell, so please link with this shape and this word, pride. I asked them to link this shape with the pride and this one with hunger, this one with cycle. And immediately we ask them to write it down or put the diagram. So that is immediate memory. Then we ask the person to tell that names. So give 3 shapes and tell 3 words, ask to copy in a sheet of paper, then remove all the stimuli. All the 6 stimuli have been removed. Then ask the patient to draw the shape and write the words. So now the registration and working memory is tested. Hope you understand now. This part is the person has to register all the 6. So they have done the registration and then they have repeated. This is a working memory. Ask to reproduce the 6 items after 5 minutes and again after 15 minutes. This is called delayed recall. This checks the retention ability. So this checks again our medial temporal. So if some of the items could not be recalled, give you cues by showing multiple shapes. So this, the frontal is good. That helps them to recognize that and retrieve from the stored memory from the medial temporal. So 3 shapes, 3 words is the best way of testing the early part of the memory disturbance, especially the medial temporal lobe involvement. Sorry. Next slide. Next slide, please. Thank you. So semantic memory, previous one. So semantic memory is nothing but these are the facts, rules, and principles. Asked to name the pictures, match the pictures with words. So though I said that it is very easy to classify these things semantic and episodic. For example, previous slide. So the semantic memory for you, Queen Elizabeth visited, we last Queen Elizabeth, and then in the history that you would have read that she visited India on 50th Independence Day and she visited Jallianwala Bagh. So these are the facts. So this is a semantic memory. But I was around 15 years. My father was part of organizing that function when she came. So I visited the place. I was with the Queen Elizabeth. So for me, that is an episodic memory. But for you, that's semantic memory. Why that is episodic memory for me is that it is autobiographical for me. I know the time when I was around 15 years, this happened. And I know the incident, what happened on that day. So the same thing can be episodic memory for me, for you. So that's the reason we always tell the students, you better convert or learn as an episodic memory. You involve in case history writing and taking up the case file and elaborating that, so that all your semantic will be converted as episodic and you will have a good memory. And especially when it is a visual, it will be retained better. So at the same time, we should learn about our own memory system. So these all should be episode. When you present a case in the before the examination or in the ward, definitely you will be learning more and more rather than the reading. So just reading with the textbook is semantic memory, case presentation is episodic memory. Hope you understand better now. Next slide. So testing procedural memory is that's not possible in clinical setting as the activity of daily living from the patient that you can get that. So they say that the person was cooking earlier, now not cooking. So probably they have lost their ability, driving earlier, not able to drive. But it is seldom lost in neurological disorders. By the time they will have other major motor dysfunctions and attention problem. Next slide. Next slide, please. So to put it very clear, previous slide, please. So to conclude about the memory part, I have taken today only the memory part. So the immediate memory or working memory, the anatomical localization is prefrontal, frontal circuits. Short-term memory is episodic memory, which is autobiographical, time-tagged, and there is a content in it. And it is a medial temporal lobe. So long-term memory is semantic memory. It's a lateral temporal and other cortical area. It's a long-term usually. And motor memory is the basal ganglion and cerebellum. Next slide. Those who are interested in knowing further about the higher mental function, I recommend Professor Madhusudanan, Professor Anand Kumar, and Professor Anand Kumar, one of the best book, Neurological Evaluation, Pills and Pitfalls. I have taken most of the message information from the book. I think I conclude about the memory examination and higher mental function examination.
Yes, thank you, Dr. Balaguru. It was a beautiful thing and would have liked to go on. As you have said, you will send the slides, and I know there are many more things in your slides which will be very helpful for the PGTs. We will definitely upload that in our groups. And now I think will be moving on. Professor Pal.
Yes.
Dr. Nandini. Dr.
Yes,
Nandini.
Yes.
Yes, madam.
No, Dr. Balamurugan has
Yes,
given
madam.
an excellent discussion on memory and higher function. I would just like to endorse what he said, meningoencephalitis. That is a possibility. But again, with such a severe papilledema, it seems to be less likely. And another thing, that there is absence of fever. There is no history of fever at all. And
No next
there are no meningeal signs. So this
Yes.
again indicates, as he has said, probably an immune compromised or immune deficient state in which you will not get these body reactions like fever and meningeal signs. So we have to think in those terms also. Thank you.
Yes, madam. Yes, madam. I fully agree. Absence of fever is one important sign to suspect immunosuppression. And when there is severe immunosuppression, we may not get neck stiffness. And as madam rightly said that the body is not reacting. That's all. Thank you. Thank you, madam.
Shakshi,
Yes, ma'am.
you go back to your other screen, and I would ask Dr. Pal, sir,
Yes.
since we were planning to also discuss a little bit about how to assess an unconscious patient, and you had, would you like to say certain
Yes,
things
yes.
about that?
Yes, I say in very brief because we have a more learned panelist to discuss all these points. But very important issue is how we will approach a unconscious patient from the neurological perspective, because we are dealing with now cases of some patient with some neurological features. So first, what is consciousness means is that your alertness about self and environment. So unconsciousness has a two dimension. One is arousal, one is cognition. Arousal is basically the primitive function, is the function of the brainstem and thalamus. But cognition is a newly developed facet of the higher function, that is the function of the cerebral cortex and subcortical nuclei. What we see, what we utter the terms coma, stupor, drowsy, these are basically the lowering of the consciousness. But whereas the delirium and confusion means clouding of the consciousness. So when we are approaching the patient or examining the case of unconscious patient, we see two examine is very important. One is the sensory and or the response to a sensory stimuli, or you can say painful stimuli, and the eye examination. Because the RAS system basically start from the brainstem and within the RAS and extend up to the hypothalamus, but within the RAS system, when the spinothalamic tract passes through the brainstem, they give the collaterals. Or also the cranial nerve nuclei that governs the or control the eye movement, they are embedded in the rash system. That is why response to a painful stimuli and the eye examination is very important when you are dealing a unconscious patient. So regarding neurological examination, first important issue is the assessment of the higher function. That is whether it is a disorder of the arousal or disorder of the cognition or disorder of the orientation. That will give you some idea regarding the site of the lesion, because our primary objective is to anatomical localization of the lesion, then the pathological diagnosis of the lesion, then the etiological lesion. So for every diagnosis, there are these three components. So first we have decided whether what are the level of the disorder of the arousal, whether the patient is conscious, drowsy, stupor, or coma. And here one point to mention that usually we assess this by Glasgow coma scale, but Glasgow coma scale, Dr. Balu has not got time to discuss all the patients. Also have some limitation. That is why when the patient in ICU, particularly if the patient is ventilated, we can have another scoring that is called full outline for the unconscious, that is called 4. Here we can include the brainstem reflexes and breathing pattern, and this is more useful for a more critical patients that we can assess by these tools. And eye examination, what I do very important because of the presence of cranial nerve in the rash system. And for example, pupillary size, pupillary shape, pupillary symmetry, pupillary position, reactivity, all these points you have to observe. And regarding, I will not go in details about the issues. What are the diseases that cause the pinpoint pupil, or what are the diseases that can cause the large pupil, so these are the things we will observe. And asymmetry is very important because in metabolic encephalopathy, pupil will be symmetric and equal size. But if the pupil is asymmetric, because in unconscious patient, we will divide in the two categories, either structural lesion or metabolic lesion. In metabolic lesion, metabolic encephalopathy, both pupil will be of equal size, and symmetric and reacting to the pupil. But if the pupil is asymmetric, one pupil is reacting, other pupil not reacting, or both reacting, but size is discrepancy regarding the size, that indicate more a structural lesion. So, pupillary asymmetry, particularly when the third nerve is involved, that is very important. And false localizing sign, I think later on Professor Inkirai may discuss. So, pupillary reactive is very lost, and it is so important. Even if the Glasgow coma scale is 3, but pupillary reactivity is present, that means there is some chance of revival of the patient. So, pupillary reactivity loss means the brainstem is damaged. There are also few drugs that can cause the fixed pupil, like the barbiturate, phenothiazide, and you should keep this in mind. And for every unconscious patient, because I told previously, your basic idea is to detect the site of the lesion. So another is a ciliospinal lesion that involves the pathway below the foramen magnum. Basically, in the tectal and pretectal lesion, the ciliospinal reflex remains intact, whereas the pupillary reflex is lost. Eye movement is the position of the eye, very important, and observe from the nystagmus that, and the pattern of nystagmus will again give some clue regarding the site of the lesion. If the eye is deviated towards the paralyzed side, that indicates the brainstem lesion. But conjugate eye movement away from the paralyzed side, that indicates the frontal lobe lesion. And vertical gauge deviation, that indicates more a brainstem lesion. And for an unconscious patient, is the brainstem reflex you should assess, particularly the dorsal movement, oculovestibular reflex. These are the very important brainstem reflex you should assess in every unconscious patient. If the oculocephalic reflex is intact, that means lesion is above the supratentorial lesion. In the infratentorial lesion, usually or brainstem lesion, oculocephalic reflex is lost. Fundoscopic examination, Dr. We will discuss later on separately. So this is the pupillary reflex. Regarding the motor examination, very important. in unconscious patient, suppose patient came with in a CVA, very difficult to assess the hemiplegia in because patient cannot follow the command. But here you have to observe few of the salient feature like the tonicity of the limb, whether limb is flaccid or palpebral fissure or deviation of the angle of mouth. This will give some clue about the particularly the tone and movement with the stimulus. This will give clue whether patient, even if patient is unconscious, patient has hemiplegia or not. And very two important feature you have to mention. One is multifocal myoclonus and twitching. Multifocal myoclonus in this patient you may have the metabolic or toxic etiology. And another unconscious patient, sometimes we see the patient is unconscious, but patient is not improving at all. In this patient, we should keep in differential diagnosis. Why the patient is not improving is a non-convulsive status epilepticus. Here we may not get the full-fledged seizure, but we can get some twitching in the tongue, fingers, facial muscles. So if you observe a twitch, patient not improving, and you observe twitching, we should keep in the mind about the non-convulsive status epilepticus. And if you do not address, patient will never improve. And I told before, the motor response to stimuli is very important. What type of posturing you are getting? Posturing you can get in two ways, either abnormal flexor response or abnormal extensor response. And symmetrical posturing in response to stimuli we usually get in toxic or metabolic disease, whereas asymmetric posturing we get in the organic disease. And two important definition you should remember: one is the decorticate posturing, one is the decerebrate posturing. Decorticate posturing means lesion is above red nucleus. Here on stimulus, upper extremity will be adducted and flexed, and lower extremity will be extension. That means lesion is above red nucleus. But the lesion is below red nucleus, there will be decerebrate posturing. Here there will be extension of the both upper and lower limb. But remember, decorticate posturing response to painful stimuli carry better prognosis than the decerebrate posturing. Sensory examination, appreciation of sensory stimuli is variable, and you have to compare the response or the withdrawal in response to the sensory, and it's a very delicate examination in an unconscious patient. Reflexes usually in unconscious patient is depressed, and you observe the plantar and also the frontal release signs. Meningeal signs, madam is discussing. If there is a immunocompromised state, you may not get the, or patient is a deep coma, you may not get the meningeal signs. And abnormal movement you examine for the whether tremor, asterisk, seizure, myoclonus, you try to observe in the all patients. So this is very brief, just few highlights I have given. Our idea from this examination is because every anatomical area of the brain has a particular features that manifest. So by examining all these features, you have to identify what is the site of lesion, whether lesion is the brainstem or lesion is the cortex or subcortical area or thalamus or other area. If it is the cortex, whether it is the parietal lobe, it is the frontal lobe, it is occipital or temporal. So anatomical localization, then the pathological localization, pathological diagnosis, then the etiological diagnosis. This is the basics of and divide the two part, whether it is a metabolic disease or it is a structural disease. So this is the in brief, very brief, the assessment part and the few tips I have given regarding the examination of an unconscious patient. So Dr. Balamurugan and Dr. Chamara is there. They can give more expert comment regarding this aspect.
Yes, sir. But I think first we should move on with the case a little bit because it has many other aspects. And I would request Shakshi quickly go on to the next, and you go on to investigations after you finish your examination. Okay.
Okay, ma'am. Next, after the nervous system examination, we examine the gastrointestinal system, which showed that there was enlarged liver, which was around 4 centimeter, which was palpable 4 centimeter below the right costal margin, as in the liver edge was felt 4 centimeter below the right costal margin. It was firm in consistency, non-tender, non-pulsatile. Surface was smooth. Liver span was around 14 centimeters. Spleen was also moderately enlarged, palpable till about 5 centimeters below the left costal margin. Rest of the examination was non-contributory. The cardiovascular and the respiratory system examination were non-contributory. Coming to the investigations, the investigation showed us that the patient had a slightly low hemoglobin of 11.9. The total count was also less, 3,600. Sodium was 126. CRP was raised, 5.6. LFT albumin level was slightly less, albumin of 3. And we had transaminitis. SGOT was 142, SGPT 64. On admission, the patient had a fever spike of around 102 degree Fahrenheit. So we investigated the entire fever profile. The malaria and the dengue tests were negative. Urine, blood, and stool examinations were also non-contributory. Sputum sample was sent, which showed that there were 15 to 20 pus cells. Gram-positive cocci were present. However, sputum CS and the Zn stain were non-contributory. Moving on with the radiological investigations, the ultrasonography showed that there was periportal lymphadenopathy, largest measuring around 8 mm, splenomegaly. There was also edematous GB wall with minimal ascites. The echocardiography of the patient was within normal limit. This is the chest X-ray of the patient, which is within the normal limit, was non-contributory to our case. The MRI brain of the patient shows T1 weighted post-contrast axial section of the brain showing multiple bihemispheric wing enhancing lesions of variable size distributed in the cortical and the subcortical areas, with some lesions having perilesional edema as well. CSF lumbar puncture drainage and CSF study was done, which showed a raised cell count of 260. 90% of them were lymphocytes, raised protein of 180 milligram per DL. Glucose levels were 40, gram stain, Zn, and India in preparation were non-contributory. We went to do a viral serology since immunocompromised state was one of our differentials, which shows that the anti-HIV antibodies were positive. A Western blot for HIV was done, which was positive for HIV-1. The CD4 count was decreased, count was around 98, along with a decreased CD3 count and a decreased CD4-CD8 ratio.
Okay, Shakshi, you wait there. Madam Deshpande? Madam?
Yes, boliye.
Yeah. Now up till this, what we have come to know that this patient is suffering from an immunocompromised state, has ring lesions in his brain, and also lymphadenopathy, which was later excised and taken for biopsy. So, ma'am, I would like you to enlighten our students on various presentations of HIV, like what are the causes of rapid weight loss in HIV or the seizures in HIV that we see. They have many etiologies, or why we have chronic diarrhea.
Okay. First of all, I would like to say that in the history when she presented, she said there is no history of high-risk behavior. And now the patient has turned out to be HIV positive. So I would like to highlight here that many of the residents, they feel, it depends how you ask for the history of high risk behavior. Many of the residents feel shy to ask the patient the risk behavior, that is one. Secondly, if they ask whether he had sexual relation with multiple women or extramarital relations, the patient will always say in the recent past. So he will always say no. And therefore, we have to highlight and we have to ask him, not now, but maybe 5 years back, 6 years back, or maybe in the past about 8 or 10 years back, because it is very important that, you know, usually the patients forget or they don't know that there is any relation between these two things. And therefore, when the HIV antibodies come positive, we are surprised. So this patient, we should ask the history of risk behavior. What exactly is risk behavior? I'll come to that later on, but it is multi-partner sex. Now, the causes of seizure, in once it is HIV positive, it could be HIV encephalopathy per se. HIV encephalopathy is seen in the initial stages, acute HIV, and then later on also when the patient progresses to the stage of AIDS. Now, this can be also because of opportunistic infections. Opportunistic infections causing meningoencephalitis. It may be tuberculosis. It may be cryptococcal or other fungal meningitis. We always believe that it is a India ink preparation, which is, if it is positive, it is cryptococcal. But we have published a paper in JAPI, if you can go through that. And we have shown there is a fungal meningitis, and all fungi are not picked up by India ink preparation. So it may be aspergillosis, there are geotrichium, so many other fungi which cause a fungal meningitis. So it may be meningoencephalitis. Then the seizure, the cause is opportunistic infections, and the commonest that we see in HIV is toxoplasmosis, tuberculomas, CNS toxoplasmosis, CNS tuberculomas, and also we have seen cryptococcomas. And amongst the malignancies, the commonest which causes this CNS manifestations is CNS lymphomas. Next slide. Then you ask me about the HIV diarrhea. HIV diarrhea is because of the opportunistic infection, and the commonest opportunistic infection is because of cryptosporidia, microspora, and isospora beli. It may be because of tuberculosis of the intestines, and there are very many manifestations of tuberculosis of intestine, but we can get diarrhea, and stool examination will show us the AFP, or it could be fungal infection. What we fail to do is that we have not instructed our pathology or microbiology lab to gear up to find out the opportunistic infection. Therefore, the stool examination is carried out in the routine manner, and then they give us the report, no ova, no cyst seen. So when we want to screen the patient, or when you know it is HIV positive, you must specify to the pathologist that you would like to examine the stool sample for opportunistic infection. It is a modified AFB stain which will pick up cryptosporidia and microspora. And lastly, there is HIV itself causes enteropathy. It causes venous atrophy and denudation and causes HIV enteropathy. Next slide I would like to show. And as you can see here, this is the modified AFB stain of the stools, which is showing the cryptosporidia. The second slide is showing isospora beli here. Okay, and this is the intestinal mucosa, which is lined, submucosal part, which is lined by the cryptosporidia. And these are the cryptosporidia here in the submucosa. Next slide. So we have to instruct the pathologist to look for opportunistic infection. Then we also wanted to see opportunistic infection, particularly tuberculosis in the stool. And I had a collaboration with another hospital, and we did this as a special study. And you can see here the stool examination, the stool smear stained with Zil-Nelson, and you can see this acid-fast bacilli here in the stool. So frank acid-fast bacilli are seen in the stool. So this was tuberculous diarrhea. And then we went ahead and did some biopsies, and this is the mucosal biopsy, and as you can see the conglomeration of acid-fast bacilli here. This is complete atrophy of the villi and loss of denudation of the mucosa. So this is what is seen in the HIV patient. Next slide. And here, this is our autopsy study. Our initial 100 AIDS patients we had subjected to autopsy. And as you can see here, very classically, this is the ileocecal region. This is the ileum and the cecum. And as you can see how thinned out it is. This looks like a parchment paper. Okay. So there is so much of atrophy. And this is what we labeled it as HIV enteropathy. So these are causes of diarrhea in these patients. And also these are the causes of rapid weight loss in these patients. And your next question was about tuberculosis. Yes. Now, these are some rare things which we saw, and therefore I am projecting them here for the benefit of the postgraduate. Every case of transverse myelitis, we used to subject for MRI to see if there is any correctable lesion. And in HIV patients, we got this. You see the ring enhancing lesion. For the first time, I saw them in the spinal cord. And this was nothing else but tuberculoma, spinal tuberculoma. This was a very unusual tuberculoma here. Now, I will not dilate upon this case because I would have liked to show you the patient's response to anti-TB. But even in spinal cord, we get ring-enhancing lesions, which are tuberculomas. Next slide. I was asked to talk about HIV and tuberculosis. Now, in America, the TB was almost eradicated, and TB came back along with the advent of HIV. So when the HIV patients had tuberculosis, most of these patients had mid-zone tuberculosis or lower lobe tuberculosis or extra pulmonary tuberculosis. And therefore, the Americans immediately said tuberculosis in HIV patient, this is a case of AIDS. Now, this was early in the beginning of the epidemic when the CD4 count also was not available. And therefore, many of our physicians here also started copying it. And any presence of TB means it is AIDS. So we did the study and we showed that in India, tuberculosis being #1 infection, we get TB in the different stages of HIV with different manifestations. So if the patient is in the early stages of HIV AIDS, his CD4 count is more than 350, he will present with typical tuberculosis like non-HIV TB. So it will be tuberculous lesions, maybe infiltration, cavitation, whatever that we see in non-HIV TB, and therefore we labeled it as HIV-associated TB, which was then accepted all over the world. So HIV-associated TB. Then we had, as the immune deficiency increases, now CD4 goes down from 350 to 300 to 200. At that time, again, we get reactivation of tuberculosis. This time it is either, extensive pulmonary tuberculosis or it is extrapulmonary tuberculosis involving many organs, the commonest being lymph nodes, and then of course the intestines. We have shown tuberculomas in the liver, we have shown tuberculomas even in the thyroid, and of course the CNS. So because of the advanced immune deficiency, we said that this is HIV related. Because of immunodeficiency, there is a reactivation again, and therefore we are getting this tuberculosis. Now, both these tuberculosis will respond very well to our anti-TB treatment, but we have to start them immediately. And lastly, AIDS with mycobacteriosis. Now, this is a special thing I would like to show you. Again, in the first 100 cases of AIDS that we had autopsied in our hospital, and on gross examination, there was no sign of tuberculosis. There were no, granulomas seen on the gross examination. Even on the cut surface, didn't show anything. But the microscopic examination showed organs teeming with acid-fast bacilli. So this is a slide of a kidney, and this kidney histopathology is showing it is teeming with all these are acid-fast bacilli. Same thing is here true about the brain, and this is again full of acid-fast bacilli. I showed you the slide of stool examination, which also showed frank acid-fast bacilli. And this is the way we had seen bacilli AFDs in the bone marrow, in the liver, in the thyroid, in the absence of granulomas, and therefore we call this as AIDS with mycobacteriosis. So this is how we get tuberculous scenario in presence of HIV in India. And as I said earlier, that because this was immunodeficiency patient, this patient did not show any body reaction in the form of fever or meningeal signs, because for meningitis, there has to be an inflammatory exudate. There has to be an inflammation of the meninges. Then you will get meningeal sign. But because of immunodeficiency, this was lacking, and therefore patient did not have any meningeal sign. Next slide. I think this was the last one.
Actually, no, not last. Actually, there were two questions to you about the prophylaxis.
Yeah, you had asked about prophylaxis
and the concordance of viral load with CD4.
Yeah. Now, prophylaxis Septran DS we used to give when the CD4 is less than 200, because these are the people who are prone to develop more and more opportunistic infection. Please remember, when the person reaches the stage of AIDS that is less than 200, and more so when it is less than CD4 less than 100, then we get the human body is a museum of pathology. Nowadays, NACO has also advocated Isoniazid prophylaxis 300 milligram per day for 3 months. Next slide. And then you had asked me about the viral load and CD4. Now, as we expect, you had also asked me what is important between the two or something like that. Now, these two are different parameters. Viral load we measure to see how severe is the viral infection. So that will give us the HIV viral load. While CD4 is a parameter of immunity, and therefore the CD4 count will tell us how severe is the immune suppression or immune deficiency. Now, when there is a concordance, the viral load, because of antiretroviral therapy, is suppressed. Or in the early stages, in the acute HIV syndrome, once the acute HIV stage is over, then the viral load goes down and the CD4 starts rising. This is concordance. So low viral load, high CD4. Patient is responding to our ART. Viral load is high. That means there is a virological failure. The viral load, in spite of ART, the viral load goes on increasing. Virological failure. And because of this virological failure, again, there is a suppression of CD4, and therefore CD4 is suppressed. So this is concordance. But we have also seen discordance. That means the viral load is low and CD4 is also low. This is possible. Remember two conditions, because unless we are very specific that we ask them to measure HIV-1 viral load or HIV-2 viral load. If you just send viral load and they will measure HIV-1, but if the patient is HIV-2, then viral load will be low and the CD4 also will be low. Similarly, virological failure, we have seen patients that viral load is also high and the CD4 is high. These are discordance. There are different reasons for this, but that is, these cases are very few, and usually we will find concordance that with antiretroviral therapy, which acts on the virus, so the viral load goes down, and as the viral load goes down, the CD4 recovers and the CD4 count goes on rising. Next slide.
I think, thank you, ma'am, for this.
Now,
this,
just 1 minute,
yes.
because you had sent me the slides and you had said that rectal mucosa biopsy was taken and there were multiple ulcers. This is again for the residents I am saying that when we ask for the high risk behavior, you must know what exactly you are probing. In India, heterosexual transmission is more common. So either they go to red light area or they have multi-partner sex with the woman and one of them infected, so they get infection. But don't forget that there is another community also, and that is a gay community. And particularly in the gay people, we see these rectal mucosal ulcers. So now once you have seen these ulcers, we should go back and ask the history for this. Of course, it's not going to help this history. It's only for our, education and for a community awareness. That's the reason that we ask for this high risk behavior history, and of course for our diagnosis. There was one question, or there was one doubt, that this patient was operated for hernia, and could it be the infection after the surgery? I will not support this, because that means we are blaming the medical fraternity for not observing the biosafety measures. That is one reason. And second, more scientific reason that I would like to give, that he was operated just 2 or 3 years ago for the hernia, and within 3 years,
yes.
So within 3 years, he cannot deteriorate to the CD4 of less than 100. So this will take at least 8 to 10 years for the decline of the CD4. And therefore, I would say that history of exposure or high risk behavior must have occurred 7 or 8 years earlier than when the patient presented. And now coming to his drowsy state, everything is explained. The diarrhea causing hyponatremia and multiple ring enhancing lesion. Now only thing we have to see what is the etiology of this multiple ring enhancing lesion. But otherwise, this case appears to be lymph nodes, the ring enhancing lesions, meningitis, CSF picture again favoring TB meningitis. So this is an extensively disseminated tuberculosis in immune deficient patient. Thank you.
Yes, ma'am. And only one message that madam has very categorically put forward, and I would like all residents to know, is that when you have an immunocompromised patient and you send the stool for testing, please specifically write what you are looking for. Otherwise, what ma'am has said, they will only send the routine OPC report, which will not help. Now, Shakshi, what did we get in these investigations? And you go on.
Yes, ma'am. We the patient underwent upper GI endoscopy and lower GI endoscopy. As ma'am said, the significant finding in lower GI endoscopy were multiple erosions in rectum along with small internal hemorrhoids. We took the rectal biopsy. The rectal biopsy ultimately showed that there was non-specific inflammation, and it was not very specific to any particular thing. This is the upper GI endoscopy report, which doesn't show any very significant finding. As far as the colonoscopy report, which also shows mild erosions. In order to evaluate the small bowel and to see specifically the ileum and the ileocecal junction, we underwent a CT enterography, which showed that there was a stricture in the ileal loop. There was splenomegaly with tiny granulomatous foci, probably small infarcts, mild ascites, along with retroperitoneal lymphadenopathy.
Okay, is Dr. Chamara here? Dr. Chamara?
Hello. Yes, I'm here.
Hello.
Yes,
Yes.
actually, Shakshi has shown what they got in these. What would be your comment about these findings?
Yes, now this is a patient who is immunosuppressed and then was found to have tuberculosis. And then as previous speakers mentioned, the ileocecal involvement in tuberculosis is very common. So as in this CT as well, there is a stricture in the ileal loop, and then there's a granulomatous focus as well. But when it comes to the diarrhea history that she presented, basically it was more in favor of a large bowel, but probably it could be a mixed type because the patient was having some involvement of the rectal mucosa and some proctitis as well. So which can lead to the symptoms like tenesmus and then having mucus in stools and all that. But at the same time, there is some form of a small bowel involvement, particularly in the terminal ileum. And then there is some retroperitoneal lymphadenopathy and mild ascites as well. So probably that explains a mixed type of a diarrhea in this patient.
Okay, thank you. And Dr. Balamurgan, are you there, sir? Dr. Balamurgan?
Yes, madam. Yes, madam. I'm very
Yes,
much.
one thing actually we were just missing. I would just like to ask you about the MRI, which showed those multiple ring lesions. Would you tell the students what should we think in when we get such a picture, and whether MR spectroscopy would help in differentiating this?
This patient had, as the MRI is concerned, multiple ring enhancing lesion MRI. So, but in the context of the clinical context with the immunosuppression, so straight away we can go for a multiple ring enhancing lesion in an immunocompromised patient in order to discuss a lot of other possibilities. So in that situation, we can straight away go, if it is not an immunocompromised, the DD will be, close DD will be of neurocystic sarcosis versus tuberculosis. In immunocompromised, I would go for a tuberculosis, cryptococcal, fungal, lymphoma, and these are the DDs we have to think in terms of multiple ring enhancing lesion. And when you look all other pictures considering the gut lesions and other lymph nodes in the supraclavicular, more likely it is a multiple ring enhancing lesion. The brain is more likely of a tuberculosis. So we can go ahead with probable tuberculosis, but again, is it only tuberculosis or in addition, because as madam said that they may be having tuberculosis with cryptococcus. So when the CD count is less than 200, they're more likely to go for a cryptococcus also. So the CSF analysis definitely will help us to say, in addition to the multiple ring enhancing lesion, more likely tuberculosis, whether the person is having toxo plus crypto, possible in this case.
Okay, thank you, sir.
Dr. Nandini, I would just like to add, again for the students, because of my experience in HIV, I'm saying that although there are multiple ring enhancing lesions, the neurological deficit, focal neurological deficit comes only because of only one lesion. The other lesions remain silent and we pick them up only on imaging. That is one, because sometimes we used to wonder that when there are multiple lesions, but deficit is pointing only or localizing only to one lesion. So that is possible. So one manifests, but the other remains silent. Of course, they are there, so we have to treat. The second point I would like to say that this is a CT picture that they are saying that the small infarcts in the spleen and granulomatous foci. I don't know how on the CT they have diagnosed granulomatous foci. It must be hypoechoic areas. But we have seen again that what looks on sonography or CT as small infarcts in the spleen, they are actually on aspiration small abscesses in the spleen. And again, they are cold abscesses. So just keep it in mind that tuberculosis, this is a disseminated tuberculosis. In addition, there will be, as I said, it's a museum of pathology. You can get multiple lesions, which we have to look for and treat. Thank you. It was a very interesting case.
Thank you, ma'am. Thank you. Shakshi?
Yes, ma'am.
Dr. Chatterjee, can I have a small comment?
Okay. Yes, sir. Yes, sir. Definitely.
I joined, it was excellent discussion. I was hearing like a student and really enlightened, and your questions were excellent. So regarding the ring enhancing lesion, I fully agree with Dr. Balanaganthan. He has told the right thing, but only one thing I like to tell, that MRS is a very good option, what you have actually mentioned, that sometimes MRS can help you to distinguish between the tuberculosis and neurocysticercosis. These are the two things in Indian subcontext, but not of course in this case, but the most all probability this is a tuberculoma, multiple tuberculoma. But if you go for an MRS in tuberculosis, there is choline peak is very high and lactate peak is low and N-acetylcysteine is low. Whereas in neurocysticercosis, we do not get these types of peaks. So this is one of the way we can find out. Otherwise, it is very difficult sometimes. Sometimes if you see the neurocysticercosis in the different phases of evolution, starting from your colloidal cyst, then your granular cyst and nodular cyst and calcified stage. And if you find the scolex, all these things will suggest this probability of neurocysticercosis. Still, it is very difficult 100% to say from your MRI picture. Sometimes this MRS helps you, but until and unless you go for a biopsy, it is not possible. But it is not possible. Biopsy is not possible, is not feasible also. So in most of the times, we depend on the clinical suspicion and also on the presentations of the patient and the clinical picture. Thank you.
Yes, sir. Yes, thank you, sir. Thank you very much. So, Shakshi,
Yes, ma'am.
go on.
Yes, ma'am. Since we had already found left supraclavicular group of lymph nodes palpable, so biopsy was taken under ultrasound guidance. The lymph node biopsy report showed us that there was granulomatous lymphadenopathy consistent with tuberculosis. We did the MTB gene expert on the biopsy sample, which was positive and rifampicin sensitive. This is the slide showing the lymph node biopsy of the patient, where we can see the granulomatous lymphadenitis.
Okay. Now, Dr. Supriyo Sharkar, sir, he is with us, and I would like him to discuss now some certain things about tuberculosis, because ultimately this case, along with immunocompromised state, has a disseminated tuberculosis. And sir, what would you like to tell us about disseminated TB, what is presumptive EPTB, and about the indications of various diagnostic tests? Shakshi, I think you have to skip one or two slides and go on to the slides that skip. Okay, sir.
Okay.
The slide
previous slide.
Yes.
Before going to your question,
The slide before Shakshi.
Yes, previous slide. Previous
Yes.
slide.
Yes.
So before going to your question, I want to highlight some points. Number one, my first case about HIV. I was in North Bengal, and at that time, a young lady came to us with vague respiratory symptoms and also non-specific chest X-ray. I admitted her. Next day, she was complaining of GI problems, and next day she was present. She had some neurological problems also. So I was confused at that time. And one day I was talking with her father, and he told me that she was eloped to Mumbai, and after few years he returned back with these symptoms. Then I unofficially collected blood and go to the blood bank and tested. This is my first case of HIV. So HIV infection may present with that. Number two, regarding the tubercular meningitis, sometimes neck rigidity may be absent, and six-month palsy is a very important sign. And I have seen many cases of six-month palsy with tubercular meningitis, and one case of bilateral six-month palsy in the malignant anti-malignant drug oncovid therapy. And the third thing, that the coma or the decreased cerebral activity may be due to vasculitis. This is one thing. And regarding cervical lymph node, supraclavicular lymph node are not common in tuberculosis, and usually we found them in lung malignancy. And in tuberculosis, classically the lymph nodes are in the posterior triangle. We have to exclude scalp infection. After that, we should consider tuberculosis. Now, regarding what is presumptive extrapulmonary tuberculosis, in our subcontinent, all cases of extrapulmonary, all diseases, and should be considered as tuberculosis of any system. And there may be some specific organ-specific signs and symptoms like pleural effusion, pericardial effusion, meningeal irritation, ascites, abdominal lump, acute intestinal obstruction, swelling of the lymph node, pain, swelling joints, gastrointestinal or genitourinary manifestations. And sometimes it may not be present always, the constitutional symptoms like weight loss, persistent fever, and night sweat. Next. So what should be the investigation of choice? Now, the Jaden stain is now obsolete. We are using oramine rhodamine stain, but it should be remembered that CBNAT is first, then smear. Do not go for in extrapulmonary tuberculosis, do not go for the smear. Always go for CBNAT, because CBNAT is more sensitive, and CBNAT give the diagnosis of tuberculosis as well as rifampicin resistance. Next slide. And as per the NTP program, now we can see that CBNAT is fast. No, there is nothing like the smear. There is no scope of smear examination. And if CBNAT, one point is that when appropriate clinical sample is available. And if the clinical sample is available, then we must go for CBNAT. And when CBNAT is positive, we can call it the microbiologically confirmed extrapulmonary tuberculosis. When we do not get the sample like tuberculoma, or when the CBNAT is negative, but clinically there is a strong possibility radiologically or biochemically and clinically, then we diagnose the case as clinically diagnosed tuberculosis. Presence of granuloma, epithelioid granuloma, also suggests that is clinically diagnosed tuberculosis. Next. Now, next question is, what is disseminated tuberculosis? Disseminated tuberculosis is when there is hematogenous or lymphatic spread from the lung. And it is clinically characterized by involvement of two non-contiguous organs, and also infection of the bone marrow, the blood, and liver. The miliary tuberculosis is one form of disseminated tuberculosis when the lesions are less than 2 millimeters. Now, disseminated disease can occur with the primary infection or with the post-primary infection. Now, one thing is clear, that when lung is involvement, sometimes other involvement of the other organs may be submerged by the findings or manifestations of pulmonary tuberculosis. Like in pulmonary tuberculosis, abdominal tuberculosis is very difficult to diagnose, and we should suspect abdominal tuberculosis if there is unexplained anemia, if there is unexplained edema, or if there is loose motion. In HIV infection, if there is loose motion, then another thing that has been missed here is that avian intercellular infection. That is also common. Now, what HIV do it, that if I am infected with tuberculosis, my chance of getting active tuberculosis throughout my lifetime is 10%. But in HIV infected person, it is 10% per year. So the activation is much more common. Next slide. Now, what is the characteristic of the extrapulmonary samples? Now, liquid we can take from the pleural fluid, ascitic fluid, pericardial, meningeal, or early morning gastric sampling aspirate. FNAC samples from lymph node, tumor, cold abscess, and needle wash. Sometimes we have to do because the sample is so small or so little. So we have to, but it is not a good sample. And solid samples. It is very important that the solid sample, the yield is very more than the liquid samples. But the problem with solid sample that it has to be emulsified, and that requires biosafety chamber, so it is not possible anywhere. You can see the lymph node sensitivity 83%, CSF it is 81%, and pleural fluid. Surprisingly, in pleural fluid it is less than 50%. But always go for CBNAT. If they are positive, then you can confirm the diagnosis. If they are negative, that doesn't rule out tuberculosis. And liquid samples should be sent with Falcon tube collected from chest department. And for solid sample, very, very important, half of the sample should be sent with normal saline. With formalin, you cannot go for the CBNAT. And always prefer the hospital settings because the LPA is not done outside. The next.
Yes, sir. Actually,
now this is.
No.
Okay.
आगे जाओ, पीछे जाओ. What is happening?
Okay. No.
Okay.
Yes.
I think some slides were not. Sir, I'll ask you. The slides. I think there is some problem. I would ask you something. What to do if there is rifampicin resistance said to be indeterminate in CBNAT? I think the slide is not there, but sir, if you would, one thing is this, and what is a line probe assay? These two things you would elaborate.
The CBNAT report may come as the both AB smear and CBNAT may be negative. In that case, we have to clinically assess the case. Second is smear and CBNAT both are positive. In those cases, we can diagnose easily, microbiologically confirm. If any one of these two is positive, then we can diagnose tuberculosis. And one thing is that if the smear is positive, CBNAT is negative, in those cases, we have to suspect atypical mycobacterial infection. Now, three things left. One is invalid result, or there is some error, and what you are mentioning that the CBNAT detect mycobacterium tuberculosis, but the rifampicin is indeterminate. In that case, we can repeat CBNAT from the second sample, or we can go to line probe assay or liquid culture with DST. Another, on the vice versa, there is one possibility is that in scanty samples, rifampicin resistance may be falsely detected. So if the MTB is scanty, that is needs more cycle time, in those cases, rifampicin resistant report should be taken with cautious.
And sir, about the line probe assay and liquid culture, if the students should know at least what they are.
Now, in case of line probe assay, there are two. One is the first line and second line. First line, we can detect the resistance to INH and rifampicin. On the second line, we can detect with the fluoroquinolones and injectables, sometimes the methamotor. So line probe assay the main problem is that the version 1, what we are using, there must be positive samples to go for line probe assay. So in our National Tuberculosis Control, National Tuberculosis Elimination Program, now it is called, if CBNAT shows no rifampicin resistance, in those cases, we have to go for first line. And first line can detect confirm that rifampicin resistance is there, and also presence of INH resistance. So there may be INH monoresistance or or totally sensitive bacilli. If the rifampicin resistance is detected, in those cases, we must go for first line, second line, and liquid culture. So second line and liquid culture, why liquid culture is important? The liquid culture is important because other than those 4 groups of drugs, we cannot assess the resistance pattern with the LPA. So even if the smear is negative, then we have to go for liquid culture, and when it is positive, then we can go for the LPA. And liquid culture, now the definition of extensively resistant without XDR tuberculosis is changed. Now the definition of XDR tuberculosis, MDR tuberculosis, or rifampicin resistant tuberculosis, plus the 2 first-line drugs, one is beclomethasone, bedaquiline, and another 2, among the another 2, any other. So it may be bedaquiline plus levofloxacillin, or it may be the bedaquiline plus linezolid resistance. Then we call it as the XDR tuberculosis. So diagnose XDR tuberculosis, liquid culture is very important. Previously, the Bactec 460 system was used because it needs radioactive carbon, and there is a problem of radioactive disposal. Now we are using MGIT. MGIT means Mycobacter gourd indicator tube, where in the tube, in the lower part, there is an oxygen sensor, and when oxygen is absorbed, the sensor will lit, and that can detect and to avoid the radioactive things.
Okay, sir. One last issue, which is a big problem, is what is the status of empirical therapy? We are in real life often faced with situations when we cannot prove that there is tuberculosis, but the guidelines are very strict nowadays regarding whether you should go for it. So what is your comment on that?
Now, one thing that should be that the trial ethica, that should be totally banned. There is no scope of trial ethica. And I have already told you that there is a scope for the clinically diagnosed tuberculosis. So you should have reasonable reason to diagnose clinically the tuberculosis. Suppose in these cases, if other manifestations are not there, there are tuberculoma in HIV backing. So we can diagnose this case as the clinically diagnosed tuberculosis. And sometimes there is a problem in the local, because of their ignorance and less knowledge, they do not accept the clinically diagnosed tuberculosis. But in those cases, we have to consult a pulmonologist, and if they write in their prescription that it is extrapulmonary tuberculosis or pulmonary tuberculosis that is clinically diagnosed, they are bound to give antitubercular chemotherapy.
May I do one comment, Professor Sarkar? One common mistake I will say from our part, we see on the basis of ADA, we try to do the diagnosis. When we are not getting sputum negative or CBNet not diagnostic or non-reactive, only ADA is high, we try to give the ATD. I think here we should be more cautious, because ADA is a more non-specific diagnostic tool, can be elevated in other conditions also. So before giving the therapy of ATD without any proven evidence, we should exclude the other possibilities where the ADA is raised.
Now, in case of pleural effusion, the diagnosis, there are points of diagnosis. Number 1, the exudative pleural effusion. Number 2, lymphocytic pleural effusion. Number 3, the ADA more than 60. Now, ADA is a less positive prediction value, but it is more negative prediction value. So if ADA is less, then the possibility of tuberculosis is less. And another important, very, very important point, we usually miss that we have to exclude other causes clinically.
Yes.
before
Particularly
starting
malignancy.
antitubercular drug. There may be many causes of
Many
proliferation.
causes,
Maybe
many
no.
causes. Exudative pattern is
Clinically, we have
found.
to exclude other causes of
Other-
proliferation. And when there is data is less,
So-
in those cases, we have to go for thoracoscopy, biopsy, and further procedure. It is not possible always. So in those
Well,
cases, we
biopsy.
can diagnose clinical tubercular proliferation.
Okay, sir. Very clear message to all our students is that there is no role of trial ATD, but what is important, as sir has stressed, is that clinically, when you diagnose tuberculosis, you
Clinical
can,
tuberculosis.
yes, clinical. Now, I think we have really reached to the terminal part of our class, which was extensive. But one thing I think I would like to ask Professor M.K. Rai, because I think we could discuss that, is about false localizing signs. Sir, are you there? Professor
Yes.
M.K.
Yeah.
Yes. In the course of the discussion that was missed, I think, because I failed to ask it. So would you tell us something little bit about false localizing signs and what?
Okay, Dr. Chatterjee, thank you for asking me this. But I think it will take some time, but I will be very brief, very brief. In 1 minute, I like to finish 1 or 2 minutes. In your case, there was a sixth nerve palsy. The commonest false localizing sign is your sixth nerve palsy when there is a raised intracranial pressure. And it is the longest course, as you all know. So if you find a sixth nerve palsy in the proper background of a raised ICT, then you can say that this is a false localizing sign. Simple plantar extensor may be a false localizing sign in case of your metabolic encephalopathy. You can get the bilateral plantar extensor. Sometimes what you get some problems in the posterior column, I mean in the neck, and you can get a pseudo-ethitotic movement, ethitoid-like movement. So when you get a ethitoid movement, you think that it's a basal ganglionic disorder, but it is actually due to some problem in the neck region, due to maybe related to your posterior column involvement, where there is a propriospinal defect is there. Sometimes you can get an internuclear ophthalmoplegia, which is very classical sign, as you all know, in the case of multiple sclerosis, when the MLF is involved. But this internuclear ophthalmoplegia may be found in dermatomyositis, in myasthenia gravis also. So mind you, this is also a false localizing sign. We are all acquainted with your Carnot notch sign. So you know that there is a space occupying lesion in one side of cerebral hemisphere, and it is giving rise to pressure, and it is pushing the pressure over the brainstem, and it is going against the opposite side and pushing on the crux is pushing to the side of the foramen magnum, tentorium cerebelli, and you get the sign like that on the same side. So this is also a false localizing sign. So various areas of the brain can give rise to your false localizing. Some frontopontocerebellar fibers. There is a lesion in the frontal lobe, but you get the cerebellar sign. You think that it is a cerebellar lesion, but actually the lesion lies in the frontal area. So you go for a neuroimaging study and find that there is a news vessel where there is a frontopontocerebellar fibers are involved, and actually patient is presented with ataxia, not of the frontal origin, but it is likely just like a cerebellar, but the actual problem lies in the frontal area. So various areas of the brain may be involved and can give rise to false localizing sign. So by definition, a false localizing sign is a sign which is far away from the original anatomical sign. Okay, you are getting some sign, but the anatomy is situated somewhere else.
Yes.
You are thinking that this may be related to this, but anatomy is somewhere else. Thank you.
Thank you, sir. We have Dr. B.B. Thakur with us, who is our mentor and past president of API and Dean ICP. Sir, are you there? Can you hear Professor B.B. Thakur? Sir, Professor Pal, I think is he there?
B.B. Thakur is there, but let's see. So also my friend Palaniappan is connected.
Dr.
Dr.
Palaniappan.
Palaniappan, your final expert comment.
Yeah.
I think
On every aspect, neurology, HIV, tuberculosis, every aspect.
Yeah. I would like to know the final diagnosis. Partially, I know. Let me know the final diagnosis.
Shakshi,
Yes, ma'am.
are you
Uh,
there? Yeah, show
yeah.
the diagnosis.
The
Yeah,
diagnosis is this is a case of disseminated tuberculosis in an immunocompromised patient.
Yeah.
I think you give a little the components of the case, just what we found in this case. What are the components?
Yes, ma'am. So it was a 45-year-old male patient who
That
had
is not the
presented.
component, Shakshi. I'm saying what are the abnormalities that were there?
Ma'am, we got lymphadenopathy, hepatosplenomegaly. The MRI had shown us multiple ring-enhancing lesions. We got multiple erosions in rectum on the lower GI endoscopy. CT angiography showed us ileal loop structure.
That person had HIV, disseminated tuberculosis, ring lesions in the brain, and lymphedema.
Yes, ma'am. In the lymph node biopsy, we ultimately got granulomatous lymphadenitis.
Yeah.
Okay.
Yeah,
Okay, sir.
Sakshi, yeah, my clinical, I have seen many more patients, more than in my clinical practice, more than 50 cases I have diagnosed. That's a disseminated tuberculosis. So many times we are missing HIV. Many times I have missed tuberculosis fine. Just tuberculosis fine, MRI showed we have not done the HIV. So many times HIV try thought negative, but ELISA positive. So early stage itself, you have to find it out. So disseminated tuberculosis is such a very common tuberculosis fine and iriopsoas abscess, multiple retroperitoneal lymphadenopathy, multiple, that is mediastinal lymphadenopathy, and everywhere. And multiple, as Alakate Sponte madam rightly pointed out, HIV patient always, so only typical tuberculosis, not only the other cryptococcus, other things also, it's very possible. Multiple ring enhancing lesion, not only it's a tuberculosis lesion, associated other immunocompromised patients, you are getting a viral infection also, it's very possible. So these patients, high index of suspicion is very, very important. So multiple lymphadenopathy, always you should not forget, that is lymphoma, non-Hodgkin lymphoma and lymphoma. And always early ATT and antiretroviral ART has to be started as early as possible, and complete CSF analysis. And many patients, tuberculosis patients, ileocecal tuberculosis is very, very common. Like we are diagnosing as appendicitis, finally we found out it's a ileocecal tuberculosis. Ileocecal tuberculosis, only colonoscopic biopsy will clinch the diagnosis. During the colonoscopic biopsy, sometimes Crohn's disease also can be found out. And there are multiple fistula in ano. Fistula and in ano always rule out tuberculosis etiology. And many patients, multiple, that is disseminated tuberculosis, as well as HIV patient, prostatic abscess. Prostatic abscess, if the male patients are having a prostatic abscess, unless proved otherwise, it's also always associated with HIV. Very rarely 10% patients, they are having not associated with the HIV. So disseminated tuberculosis is very common, endobronchial spread and other lymphadenopathy, all the things. I have seen all type of disseminated tuberculosis in my experience, and miliary tuberculosis also. So here biopsy clinch the diagnosis, as well as that is gene, that's a gene expert study and family sensitivity, everything you have to do. And early diagnosis and appropriately hit hard, hit fast rule has to be applied properly, and universal precaution, all the things is very important. Associated other STD disease also has to be ruled out in all HIV patients. Thank you very much, my dear Jyotir. And
Thank you.
Thank
Dr.
you.
Sakshi, Dr. Nandini, 1 second.
Yes.
Dr. Sakshi,
Yes, ma'am.
now once you have made a diagnosis of disseminated TB in a HIV positive patient, the
Yes, ma'am.
correct word will be immunodeficient patient. Because there is these two are maybe semantics, but there is a difference. There
yes,
are
yes,
many
madam,
other,
definitely.
many other
Deficit.
conditions which we call it as immunocompromised. A patient
Even
on a
diabetes
long-term
also
steroid
immunocompromised.
therapy. Yeah,
Okay.
long-term steroid or diabetes, they are called as
Nephrotic
immunocompromised.
syndrome also.
Here, this patient should be called as immunodeficient. And secondly, as per the national guidelines, all TB patients should be subjected to HIV test because if it is positive, we can start antiretroviral therapy immediately. Thank you.
Thank you, ma'am.
So now,
One
I
comment,
request.
in our national tuberculosis elimination program, all TB patients should be screened for HIV and all HIV patients should be screened for tuberculosis.
TB. Now I come to my Sri Lankan friend, tips for our students. Dr. Chamara, please. Nandini, he is connected.
No, I think he is not there. Sir, you please conclude this class now, I think, and you please tell the students about the how they will get answers to the questions that are in the chat box, because we are not going to discuss them now. You please tell what we are going to do subsequently.
So the PPT we'll put in the group along with the video that we prepared by few days, and the questions what I received from the question answer box, the answer will be added in the PPT at the end, question and their answer, and we'll put in the groups. All the groups I will put there.
Okay.
So thank you. I hope so many good tips you have got from our learned panelists, and I'm hopeful this type of class we will conduct once in a month and will be helpful for you. Any question, any suggestion you send to us, and we'll try to incorporate in next classes. Thank you. So, madam, your final message for the students. Madam.
Maybe, but one thing I must say is, Shakshi, you have done a good job. But the thing is, maybe there were a little, some of the slides of some of the panelists, I don't know, they were not there, but doesn't matter. Your presentation was good and it was a very great effort. And I thank all the panelists.
Now, madam is connected. Madam, your final message for our students.
Okay, Madam Deshpande.
Okay.
Now, madam is
I
connected.
didn't know that you are asking me. No, the case was a very interesting, and now at the end of it, we all know why there is a subacute dementia in this patient, and he came with convulsions. So, he must be getting forgetful. He must be having slowly developing all these symptoms. When the patient developed convulsions, the patient's relatives brought him to the hospital. By that time, he had advanced HIV disease and he had disseminated tuberculosis. So we have to treat now both. We have to start immediately antiretroviral therapy and anti-tuberculosis, anti-TB therapy. And as you have said, that gene expert showed that it was rifampicin sensitive. That is one fortunate thing. And wait and watch how he responds to the treatment. At the same time, to reduce the cerebral edema, we'll have to use our all routine anti-edema measures also. Be careful if you are going to use steroids, because I don't think that they will help in this patient. On the contrary, they will flare up, or they will, flare up the immune deficiency. So that is all I want to say.
Contraindicated, madam. It's contraindicated. Steroids contraindicated. Yeah.
Yes. So thank you very much for inviting me for this very excellent master class and very excellent discussion from all the panelists. Thank you very much, Dr. Pal and Dr. Nandini.
Thank you.
Thank you.
Thank you, Nandini. Thank you so much. Thank you, madam.
Okay, sir, should we then?
Yes. This is the end of our webinar.
Hi, I'm John Brassey and I'm the creator of the TRIP database. TRIP is an online database that helps connect users with high quality, evidence-based clinical content to support their work. TRIP is fully web-based and is optimized for both mobile and desktop browsers, so you can use it on your PC, tablet or mobile phone. Users can search an unrivaled collection of evidence from clinical guidelines, systematic reviews, regulatory guidance to randomized controlled trials and other primary research. Let's jump straight in to show how easy it is to get great results in TRIP. This is the homepage of TRIP. You'll notice a yellow theme. This shows it's the Pro subscription version. But the way to use TRIP is the same if you're using free or Pro versions. Now let's do a simple search for croup. As I type, you'll see a drop-down appear with search suggestions. I'm going to ignore these and simply hit the search button. You're now seeing the results page with three main areas. At the top is a search box area reflecting your initial search. On the left-hand side is a search filtering area which can help you refine your results. And in the middle are the actual results. To see the article of interest, in this case the top result, you simply click on the title and the result opens in a new window. One thing you might have noticed is the use of the colours. These appear under each result and in the search filtering area. This reflects an important concept in evidence-based medicine, the evidence pyramid. This helps to convey that some evidence is better than others. In this pyramid, the high quality secondary evidence is at the top and is coloured green. And as you work down the pyramid, the colours change, reflecting the different evidence types. At TRIP, we're focused on delivering the best available evidence, so favour secondary evidence. We much prefer quality over quantity. Now, if we look back at the search results and scroll down, we can see that under each result is a pyramid, with a coloured band representing the place in the evidence pyramid. Alongside that is a coloured lozenge with the type of evidence. For example, systematic reviews or evidence-based synopsis. This principle is carried over into the filter area. Here you can restrict your results to a particular type of evidence. So I may be mainly interested in systematic reviews, so clicking here restricts the results to just systematic reviews. And you can click again to remove the selection. That's all for this video. I hope you found it useful. Thank you.